Let me start off by saying thank you, Dr. Heffler, for dedicating your life to the treatment of back pain so that I don't have to. But when we talk about the adult athlete, I really wanted to focus on the thing that I probably see the most, which is early or moderate or even severe arthritis. So this talk is going to be geared towards the treatment of all stages of arthritis, both non-operative and operative solutions for arthritis. The first thing I want to do, though, is just go over some of the basics. So what is the knee joint? Really, it's the area of the body where three different bones make contact with one another. We're talking about the femur or the thigh bone, the patella or the kneecap, and then the tibia or the shin bone. Where these bones make contact with one another, they're lined with cartilage. It's the cushion that makes motion smooth and effortless. When you lose that cushion, when you lose the cartilage on both sides of the joint, that's when you develop arthritis. So of course, everyone knows someone who's had some problem with knee arthritis, whether they've had knee arthroscopic surgery or total knee replacement or simply had injections or physical therapy. So we know that it's very common. And increasingly, we're seeing more and more older people, but also younger people who are very active, who are developing arthritis. And so the numbers of people that we're treating are constantly increasing. So we need to be aware of all the different treatment options and really try and tailor them for the person, their age, their activity level, their expectations. I'm sure you could guess what are the main symptoms that we see when it comes to arthritis. So of course, number one is knee pain. But we also see a lot of swelling, and that's when patients will talk to me about, I feel some water in my knee. Sometimes we'll drain the knee, for instance. And increase in stiffness. That typically is a more long-term problem. How do we go about treating arthritis? The first step is always trying to manage it without surgery. And that involves simple things like activity modification. And I don't try and poo-poo that with my patients. I actually tell them it seems very simplistic, and perhaps it's, I certainly don't want to come across as trite or condescending, but if there's a particular activity that seems to aggravate the problem, you may want to limit that activity. So even in my case, I had ACL surgery 25 years ago. When I go out running outdoors on the concrete, my knee starts bothering me, so that sort of thing I try and limit. It caused an issue with my wife when we were living in Manhattan. She always wanted to go to Central Park, and I said, no, I'm not going. She would make fun of me, but I said, look, I really want to try and keep my knee the way it is. Weight loss, another very, we hear it all the time, but it actually does work, and I'll go over some of the data regarding that. Bracing and orthotics, anti-inflammatories, physical therapy, and even things like acupuncture. I tell my patients that if you think that something like acupuncture is helping you, that's great. In fact, I do send some people, if they're interested, they can go and try it, and there are other modalities they can try as well. If it relieves your symptoms and it's safe to do, I'm okay with you trying. And there is some data to show that acupuncture can help. So weight loss and knee pain. I tell my patients that the knee, especially the kneecap, so if you have problems with your kneecap or your patella, the knee is exquisitely sensitive to your body weight. And you can see here, for each pound of body weight lost, that's a reduction of about 4 pounds of stress in the knee joint. Beyond that, if you're about to undergo surgery for your knee, especially a total knee replacement, which I'll do for some patients who have end-stage arthritis, obesity is certainly a risk factor for complications, including infection and things of that sort. So if you can go from the left, the woman on the left to the right, just doing that alone will improve your knee arthritis symptoms. Not that that's easy. PT. So again, we hear it all the time, but PT works. I can't explain exactly why it works, and the therapist in the room may know much better than me. So I don't pretend to know why it works exactly. We do know that by strengthening the muscles, the tendons, the ligaments, etc. around the knee, they probably absorb more of the load and the stress, and the bone and the cartilage see perhaps less of it. But muscle strengthening has been shown in various studies to improve pain. Aerobic exercise can improve function. I really do advocate for physical therapy, and there are plenty of people who were insistent when they first saw me, oh, I need surgery. I said, just try the therapy. and then after 6 weeks they're feeling a lot better, and I don't see them for a long, long time. Bracing. So bracing can also help. It's not a cure-all, and I'll be honest with you, this type of brace, which is an unloader brace, is not the most comfortable. But for people who have very specific forms of arthritis, perhaps you're very knock-kneed or you're very bow-legged, this type of brace may help. Basically what it does is it tries to take pressure off the side that's more arthritic and tries to move the body weight towards the side that's more healthy. So in this case, this is a right knee. You see that there's a bar on this side. What it does is it tries to jack open the space here so that more of your body weight goes down the healthier side over here. But they can be costly, so I do advise patients, counsel them that it may not be completely covered by your insurance. It may be $500 or $1,000, whatever the cost may be. But I do have plenty of people who, especially I have men, for instance, who are adamant they don't want to have surgery, but they want to be very active. I have people who use this. They're cyclists, they're skiers. They can do it with this brace. They can play tennis, and they're happy with it. You may have heard about the gel shots. This is viscosupplementation or hyaluronic acid injections. They have been shown in a number of studies to be better than placebo, and they may be better than cortisone shots. I think in some patients it certainly is worth attempting to do this. They're usually given in a series of 3 injections. A lot of times our physiatrists like Dr. Heffler or Dr. Kessel or Dr. Saylor will do it also under ultrasound. Cortisone shots I will do on occasion. I typically do it for very specific reasons. If a patient comes in, their knee is very swollen, they have a lot of water in the knee, I'll take out the water, and I'll also do the cortisone shot. Cortisone, I think, has some more limited utility. I'd like to think of it as if your knee is really inflamed, that's the time to really perhaps consider it. But it's not going to give you 6 months or a year of relief, typically. I mean, there are some people who can get over the hump with that flare-up and you won't see them for a long time, but that's not always the case. And then PRP, you've heard about. To say whether it really is going to be extremely helpful in an arthritic knee, there are some studies that show that perhaps it may be of value, but again, the data is so limited. And I do counsel patients that it's not necessarily covered by insurance. You can attempt to use it, it's safe, but it may not give you the results you want. The other thing I get asked about is stem cell therapy, and in fact, I even had a representative from a company try and sell me on amniotic cells. So all this biologic stuff is really exploding. The problem is we don't know what we're doing, and we don't know exactly what it does. So stem cell treatment, it sounds great. Okay, it can be an office-based procedure. If you look here, the person is lying on their stomach. There's a little area in the back of the hip that we're preparing, and we put a needle in. It's a small needle, and we try and take out bone marrow from the pelvis. And what we do then is we put it in a machine, we spin it down, we get the stem cells. But the reality is we just don't have any data on that yet. Some people are experimenting with it. But I really can't, with good conscience, recommend it to people because I really don't even know what it would do, if anything. What about surgery? So you've tried all the non-operative type stuff. It's time to really consider surgery because you're not happy with how you're feeling. You can't get back to playing the sports you want to play. It's affecting your tennis game. Paddle tennis is coming up. What am I going to do? I'm on a team. I don't want to let the people down. What are the things we can do? So arthroscopy is an option. So arthroscopy is, of course, minimally invasive. We basically make 2 tiny incisions on either side of the kneecap. We put the camera in. We look around. But I'll tell you this, if your knee looks like this, it probably won't help you that much. So there are very specific things we do knee arthroscopy for in the case of arthritis. Typically, the times I'll see where it works well and what I recommend it for are if you're having something that's floating around, what we call a loose body, that might be an instance to consider arthroscopy. But if you're just having the pain from really 2 surfaces rubbing up against each other like sandpaper, which is what arthritis is, it's probably not going to help you. And there are a number of studies over the last 15 years that have shown that. Obviously, though, if you are a good candidate and you do undergo arthroscopy, the rehab compared to some of the other options I'll show you is a lot more straightforward. So you're usually walking on it the same day, no restrictions on motion. I have you see the therapist within 3 to 5 days. Usually the therapist will have you on the bike by a week, and then by 4 to 6 weeks, you're probably going back to all your activities, typically. So the rehab is very limited, which is appealing. But again, I don't want to just do something just because it's easy. I want to do it because it's the right thing. So again, there are very limited reasons why I might consider that in an athlete with arthritis. Now, what is this crazy stuff that we're doing to the knee here? This is called an osteotomy procedure. What that means is if you're developing a subtle bow-leggedness or a subtle knock-knee deformity, we can correct your knee so that it's straighter, and that way the weight will go down the healthier part. It does what that brace does, which I showed you a few slides back. But you can imagine it's a little difficult for me to explain to patients that, oh yeah, all I'm going to do is cut your bone here, I'm going to open it up, I'm going to put something in between, and then basically I'm going to put a big plate on the side. So it's not something I usually say on the first day I meet someone. But it does work. And basically, in people who are very active, so again, I'll give you a good example. 48-year-old male, one of those hyper-competitive guys. I mean, he can't just turn it off. He's like Michael Jordan. I mean, he's going nuts. He's got to compete with his buddies. He's a big-time skier. That type of person who really wants to go back to doing those type of high-impact activities where pounding the pavement, jumping, running, that's the type of person who may benefit from an osteotomy. And there are a couple different ways we could do it. For a person who has bow-leggedness, we put it usually on the shin bone side. For a person who's knock-kneed, we do it on the thigh bone side. And you can see how you can correct it. Here, this is a left knee of someone who's very knock-kneed, and we basically realign the bone and they look a lot straighter. The advantage is you basically have your own knee still in place. We're not replacing it with any metal or plastic. The problem, it doesn't last forever. Usually people will have good outcomes for about 7 to 10 years, and then I'll have to convert them to a total knee replacement, which is actually harder to do than if they just had the total knee replacement. Also, the hardware can be quite prominent, meaning that metal plate and screws, you can imagine having this thing along the side of your thigh is not very comfortable when your IT band is rubbing all over. The other downside to osteotomy, although again, I love doing it in the right person, is that the recovery is a lot harder than, say, a knee arthroscopy. You're on crutches, and you really won't be cleared for, you're on crutches for 4 to 6 weeks. You won't be cleared for sports until we see definitively that the bone is healed and that you've recovered your strength and your motion. So that can take 6 months or longer. Now, the other thing I will consider in some adults with arthritis, especially if it's localized to just one part of the knee, is a partial knee replacement. And this option I do offer to people who will commit to doing lower impact activities, golf, biking, doubles tennis. These type of people can go back to skiing. They can go back to those type of activities with a partial knee. And the beauty of the partial knee is that you retain the vast majority of your knee, you retain the ligaments. Your motion is typically better than with a total knee, although admittedly there's a bias because people who undergo total knee tend to have more severe arthritis. But you can see here what we're doing is basically this person has a knock-knee, has a bow-legged deformity. They have a lot of arthritis. The bones are rubbing up against one another here. And then basically we replace that with metal and plastic. The plastic is in between. You can't see it. It doesn't show up on an x-ray, but the metal is the white part. The disadvantage is that it's more challenging, I think, than a total knee replacement because you have a much smaller space to work with, and you can't do as much as you can with a total knee replacement in terms of correcting deformity, etc. And also, it typically doesn't last as long as a total knee replacement. But having said that, though, when it works, in the right patient, they feel as if they have their old knee back, which most total knee patients won't say. Most total knee patients will say, I feel a lot better, my pain is gone, I can do a lot more things than I used to, but they notice that they have a synthetic knee in there. People with a partial knee typically don't feel that same sort of sensation. So when it works, it can be a real home run. You're walking immediately, and then usually by 2 to 3 months, I will clear them to do activities, lighter activities, like I said, doubles tennis, skiing, cycling. So in conclusion, when I see the adult athlete with a knee problem, oftentimes it is unfortunately, arthritis. Sometimes it's just a meniscus problem. We can treat it with a meniscectomy or with PT, but oftentimes it is some form of arthritis. And really what we have to do is tailor our approach based on how old they are, what their expectations are, what type of sport do they want to go back to, etc. And that also means perhaps they may have to take out marathon running. I mean, if you're trying to run the New York City Marathon every year and you're developing worse and worse arthritis, you may have to modify that. For my younger patients, what I'll do is I usually will do some form of arthroscopy or an osteotomy. I'm talking about 25, 30-year-old patients. People who are in their 30s, 40s, 50s, we may consider any of the options, osteotomy, arthroscopy, or a partial knee replacement. And then people who are older typically will consider more of a joint replacement procedure, although not always. But typically I wouldn't do an osteotomy in, say, a 75-year-old. It's just not worth it for them to go through that recovery, that type of pain. And admittedly, they typically have weaker bones, so it's a less reliable procedure. Okay.